Thank you, Dr. Kavanaugh. It's my absolute pleasure to be here to moderate this session of our first speaker, William Schaffner, MD. Dr. Schaffner is Professor of Preventive Medicine in the Department of Health Policy and Professor of Medicine in the Division of Infectious Diseases at Vanderbilt University. Throughout his career, he's been dedicated to infectious disease prevention and has played a pivotal role in shaping national vaccine policy through service on numerous expert advisory committees. Dr. Schaffner has advised the CDC, served as past president and current medical director of the National Foundation for Infectious Diseases, and is widely recognized for his ability to clearly communicate public health guidance. His leadership in vaccine policy and hospital infection control has set national standards and advanced patient safety. Dr. Schaffner, the floor is yours.
Well, Jean, thank you very much. Those are very kind words. And thank you, Kevin, for setting up this very rich program. Kevin asked me to talk a little bit about communicating with patients and some to the public during this time of a lot of misinformation and disinformation. So let's quickly look at the next slide, which just tells you that I don't have any conflicts of interest. And so let's begin by the next substantive slide here. I'm going to go way back to 1799 when Dr. Benjamin Waterhouse learned of Edward Jenner's smallpox vaccination technique. Dr. Waterhouse was here in New England and then said, as the ordinary mode of communicating even medical discoveries in this country is by newspaper, I drew up the account of the cowpox, which was printed in the Columbian Sentinel, March 12th, 1799. So obviously, communicating new medical and public health information through the general news media has a very long tradition. Next slide, please. Larry Altman was a physician who was one of the first people who became a physician communicator in the media. And he was thought to be the dean of physicians and other health professionals who worked in the media communicating with the general public. And he said back in 1993, he reminded us that for the general public, the media are the major form of continuing education after formal schooling is complete, which, to the next slide, I remind my colleagues that this is a teaching opportunity, and it may be, in some circumstances, often our only teaching opportunity, and it's now ever more, what with the social media, a very dominant teaching opportunity, an opportunity for communication. Now, in the next slide, that communication can be clear and appropriate and science-based, but there's also a great deal of mis and disinformation out there. Misinformation is false or misleading information that's shared without the intent to deceive or cause someone any kind of difficulty. For example, vaccines are not safe during pregnancy. Maybe something that is out there and people talk about, but there's no adverse intent in that. It's really an intent to inform. In contrast, disinformation is spreading false or misleading information with the intent to deceive or cause harm. For example, the COVID-19 vaccine is unsafe and ineffective, but buying these supplements is a proven way to protect your family. We can see that. And then the next slide, I'm basically saying the same thing. Misinformation, often innocent falsehoods, but they can be very troubling. Misunderstandings. It's a desire often of a person or persons to share content that aligns with their personal identity. It reflects certain cultural norms and values that are part of that individual's environment, or even because you think you're being helpful to those within your audience or community. In contrast, disinformation often has a connection to profit of some kind. Yes, sometimes it's directly monetary, but it could also be political and to influence followers and those who like you. And it may indeed be put out there to erode trust and create division for someone's personal gain. The next slide just illustrates what I've said in a more colorful fashion. Disinformation is frequently designed to elicit an emotion. If it's like the yellow emotion, curiosity, well, that could be a good thing, except it's so often anger or distrust, fear, concern, or a sense of tribalism to try to convert people or maintain them in a certain group that's important, sometimes for financial reasons, and frankly, sometimes for political reasons. The next slide. So I'm going to show you two slides that came out just last year in JAMA. I'm not so sure I entirely agree with the findings, but let's go through them. In this graph, the blue or teal colored bars represent the proportion of people who have heard or read a false claim. The darker bars, the red bars, identify people who think that that claim is definitely or probably true. So just hearing about it doesn't mean that you believe it. For example, we'll go from the top down very quickly. The COVID vaccines have caused thousands of sudden deaths. Well, there you have an awful lot of people who've heard that, but still a substantial proportion of people kind of accept that and think it's probably correct. Or the MMR vaccines have been proved to cause autism in children, a subject we're going to hear a lot about in the near-term future, I'm afraid. I think probably an even larger proportion of the population has heard of that over the years. Here, the red bar says those who definitely believe it is much less. I'm going to say the same thing in the next slide. At least in my part of the country, I live in Tennessee, I'm not so sure that that's correct. Here we're doing something similar. The green bars are the proportion of people who use the social media platform at least once a week. And then the proportion of people who have a lot of trust in health information on the platform is in red. You can see the distinction. Once again, at least in my part of the country, I think those red lines ought to be much longer than they are on this slide. I think the impact of social media on not only providing the concept, the information, but convincing and reinforcing people that the concept is accurate is very, very powerful and more powerful than this slide shows. Let's go to the next slide. So we in clinical medicine and public health are in the business, the activity of influencing behavior, whether it's convincing people to maintain their diabetes medications or their medication for high blood pressure or whatever health-related issues we're talking about. So let's go to the next slide. Now, behavioral psychologists have told us that influencing behavior involves two things. One is knowledge. That's something I suspect as healthcare professionals we're all quite familiar with. But the other is attitude. What do I mean? Let's look at them both. Next slide. Knowledge. Let's look at the left here. Knowledge, it's the facts. It's what we know, what we think. Facts are often numerical, not always, but often. They may be analytical. If A and B are true, then C is likely to be true, that sort of thing. I think of it as inner directed. It's what we think. And if I had to localize it in an organ, it would clearly be the brain. Now, on the right side of the slide, what the behavioral psychologists have told us is absolutely. Trying to change behavior requires solid knowledge. So everything that we have heard and I suspect all of us believe, start with the science is important and indeed often essential. But what the behavioral psychologists have told us is it's often not sufficient. Next slide, please. They say what we have to do is influence our attitude on the next slide. So here's the attitude. What do they mean by attitude? They mean what we feel as opposed to what we think. And what determines how we feel? Our social norms, the group that we're part of. What did the rest of my family feel about this? What does my community, my social group, everybody with whom I worship, the people with whom I live and interact and do business with all the time? What's in, what's cool, what's with it? This is other directed. And if I had to pick some organs, it's the heart of the gut, right? And here, the behavioral psychologists have said if we want to influence and indeed change and motivate behavior, we have to absolutely address how people feel about things, not just how they think about them. Next slide, please. What we want to do is build trust. And then the feeling part comes from making patients and the public comfortable and reassured. Let's go to the next slide and have a look at a patient. This is a patient whom you've known for a long period of time. So you have a first name relationship with Charlie, who's 63 years old. He's diabetic, he's overweight, he has mild hypertension. And before he joined your practice, there's a past history, not so well defined, that he had pneumonia at one time, sort of walking pneumonia. In any event, it is this time of the year. You, the doctor or the nurse practitioner, says, Charlie, it's that time of the year. You're due for your flu shot today. So the first thing you note is, I didn't ask, I told. And the second thing is, I said, your flu shot. I want to conjure up in the mind of the patient that there's a syringe in the refrigerator with Charlie's name on it. However, this time, Charlie says, well, Dr. Bill, I'm not so sure about that. So let's look at the next slide. And so the very first thing that should come to your mind is, whoop, yellow light. I'm going to have to pause. This will take a little extra time. What we should never do is act surprised or disdainful. What, Charlie? You don't want to get your flu shot? What are you talking about? That will get us nowhere. First thing we need to do is validate that you have heard the patient. Charlie, you have some concern. So do many of my patients. I get asked a lot of questions about flu vaccine this time of year. The patient's heard you, you've heard the patient, and you're validating it. And then you ask, how can I help you? Or what's your specific issue? What's your concern? Let me know. And Charlie says, well, I've heard about X, maybe side effects. And then affirm again, I get that question a lot. Once again, patients put at ease. And in the next slide, you will answer succinctly and generally, talk about the fact that this vaccine is given in the millions of doses around the world each year, for example. And yes, you may indeed get a little bit of a sore arm with this. I do myself when I get my vaccine, but that will pass and you'll get the benefit after. So put in the benefits, go easy on the statistics, and then bridge to comfort and social norm. I'm a very personal kind of doctor, not everybody else is this way, but I'll say immediately, my wife and I always get vaccinated, as do our children and grandchildren. And then I even say further, all the doctors in this practice trying to provide this vaccine for absolutely all of their patients. And we're working to get to 90% this year, Charlie. What I'm trying to do is normalize it. Everybody's doing it. You're going to be unusual if you don't be vaccinated. Now, you won't always be successful, obviously, but don't argue with your patient. Accept their reluctance if they choose not to be vaccinated, and then promise them not threaten, that the next time you'll see them, you'll talk about this again because it's very important. So that should always be done with a smile to keep the patient at ease. Let's look at the next slide, which is a similar case study done slightly differently. The patient says, I don't need the flu vaccine because I never get it. Doctor says, or the nurse, so because you never get the flu, you wonder why you really need it. So the doctor or the nurse is hearing the patient, feeding this back to the patient. The patient is affirmative, yes. And then they can talk about this and also anything else that concerns you about the vaccine. They're concerned about side effects. And you can see that in this instance, this healthcare provider is validating it again and then goes on toward the end to ask actually the patient's permission to say, can I tell you what concerns me if you don't get the vaccine and do get the flu? And I hope the patient says yes. And then in this particular instance, the physician or the nurse will say to the patient, with your chronic lung disease, it could be very serious if you would get the flu because it'll make your chronic lung disease worse, et cetera, et cetera. You may get pneumonia. And so that's why we think it's so important for you to get this vaccine, particularly since you're in a high risk group for complications. So there are various ways of doing this, but always listening to the patient and validating their questions. In the next slide. So in communicating, whether you're talking to the local newspaper reporter or to an individual patient, keep your answers science-based, keep your messages simple, express them clearly, and explain why it is you're stating that. Acknowledge the limitations. Influenza vaccine is a really pretty good vaccine in preventing serious disease, but it can't prevent every single case of milder influenza. Acknowledge that. Try to keep your focus positive. And then, as they say, rinse and repeat. Do it again. Next slide. I always like to quote Maya Angelou in this circumstance. And she said famously, people will forget what you said. People will forget what you did. But people will never forget how you made them feel. So try to make people feel comfortable and reassured, and that it's the appropriate thing to do to get vaccinated. That's what we're trying to do. Next slide. Now, there are those in this audience who may think of themselves principally as scientists. They're investigators. The word scientist has a Latin root, scientia, which means knowledge. So a scientist is one who creates knowledge. Others think of themselves as physicians. That comes from the Greek physic. That's a medicinal herb. A physician is one who treats disease. But in the next slide, whether you're a scientist or physician, we're usually addressed as doctor. And that word doctor has a Latin root, docere, to teach. Doctors are persons who teach. And since Jean, Ann, and Kevin reminded me that we're likely to have a large number of nurses on this talk, I did look up the Latin root of the word nurse, which is nutrire, which is to nourish, which over the years has come to mean to care for. And I would say the greatest care you can give to a patient is to help them prevent disease. Thank you very much for your kind attention.
Thank you, Dr. Schaffner.